Topic of the lecture today is alveolar diseases. How do you know which diseases to label as alveolar lung diseases? All of those diseases which lead to accumulation of any kind of substance, including pus, blood, or exudates, or fluid, or even proteinaceous material inside of your alveoli are called alveolar lung diseases because somehow they're compromising the function of the alveoli. That's why they're called alveolar lung diseases. So, in some cases, that fluid, that substance, that pus or whatever it is, can completely block the alveoli, and there's no aeration whatsoever. Those diseases are very easy to identify on a radiological slide. That okay, this patient is suffering from alveolar lung diseases because all the alveoli are in that area. All the alveoli are completely filled. There's no gas exchange. There's no functioning at all. But then there comes some diseases in which all the alveoli is not under the influence of that substance. There's partial filling of that substance, and there's partial area present for the aeration for the gases exchange. Now these diseases are very hard, very difficult for us to identify, even on a radiological slide. So first of all, we have to know that which areas are going to be affected, which areas are prone to get subjected in this kind of disease. Let's get started. First of all, let's talk about diffused alveolar damage. Diffused alveolar damage means all the alveoli is diffusely damaged. That's what this word means. So in this slide, we'll know that which areas are going to get affected, which structures we might see in this pathology, and what to expect out of it. As you can see, this is an alveoli, this is an alveolus, this is a capillary, gas exchange is happening, all the oxygen is coming this way, all the carbon dioxide is going this way. So this exchange can be disrupted by which factors? It can be disrupted by these factors, that there could be a huge edema and exudate present here, so the air won't even get in, the air won't even go in this direction, oxygen won't go into the capillary, and the carbon dioxide won't even travel back to it. So all the gases exchange has been compromised just because of the presence of edema and exudates, and it's in those conditions when all the alveoli is damaged and all the alveoli is filled with this kind of substance, not in those cases in which partial aeration is present. Then there will be hyaline membrane formation. This is a membrane which is formed in this alveolar disease, this alveolar pathology. We'll talk about hyaline membrane, how it is formed in the next slide. Next one, we have type 2 pneumocytes. Then we have interstitial edema and inflammation. We'll talk about why in this disease patient is getting interstitial edema. Next one, we have basement membrane, in which PMN is present. So let's talk about what are the basic risk factors for getting this disease. So etiology or the risk factors in this condition are drug-induced DAD, drug-induced diffused alveolar damage. What happens is that some drugs are going to affect your lungs in that way that alveoli are filled with pus or these substances. Which drugs do you think are going to affect it in that way? Chemotherapeutic drugs. All of those drugs which are going to affect the lungs in this way that it's going to get diffuse alveolar damage are chemotherapeutic drugs. Chemotherapeutic drugs are the major cause of this disease. Otherwise, there are other drugs present like like fluoroquinolones. They also affect the lungs in this way. Next one, we have radiation pneumonitis. If a patient got, for example, a breast cancer, and it was not a big lump, it was caught in early stages, and the patient is subjected to the radiations, there is a very probable chance that the patient is going to get diffused alveolar damage. Next one, we have paracoit. We all know what that is. Next one, we have aspiration. Aspiration of the gastric contents can lead to this disease. Next one, we have shock. Which shock you might think is going to be responsible for diffuse alveolar damage? Septic shock. Because of all the infection present, septic shock is going to be the major cause of diffuse alveolar damage. Next one, we have oxygen toxicity. So all of these factors are going to affect the lungs in this manner that the patient will get diffused alveolar damage. Let's talk about the pathogenesis of diffuse alveolar damage. As you can see, this is a healthy alveoli. This is the alveolar airspace. This is the capillary. Blood is moving in this direction. Air can come out and go. So gases exchange is happening here. So what will be the unhealthy lung looking like? Like this. So there's a huge difference. You can totally identify the differences present. This is the hyaline membrane we talked about that I'm going to tell you afterwards that why it happened. So first of all, we have to know what are the key factors in this. See these are erythrocytes. Where were erythrocytes present before this happening, before diffuse alveolar damage? They were present in the capillary. They were not present in the air spaces. They were not affecting the lung in any way. But now they are present here. Type 2 epithelial cells are present, which were going to be present in here. But now you can see they're just vanished. They're just gone. Next on, we have endothelial cells. Next on, we have macrophages. There was only one macrophage present. Now there are multiple macrophages present because infection is up to that level. Then we have neutrophils. We can see no neutrophils here, but multiple neutrophils here because of infection. Then we have lymphocytes. As you can see, all the lymphocytes here, but there was none here. There was none in a healthy alveoli. Next one, we have apoptotic nucleus because somehow through apoptosis or necrosis, immunity is going to take care of it. So apoptotic nucleus is here. Schizonts come in, ring stage parasites come in, platelets come in, and then hemozoin crystals and marginating monocytes, all of them just rush in this condition. So first of all, we have to identify why edema is happening. Why do you think edema will be happening? When there's a damage to the alveoli, there's going to be a damage to the endothelial lining. When the endothelial lining is damaged, the water or the fluid will subsequently pour out in the alveoli, and it will lead to edema. Next on, hyaline membrane will be formed here. So it will even complicate the gas exchange that was happening already. So what will hyaline membrane be formed of? Hyaline membrane is actually formed of the fibrin, which is present in the edema, and the debris which was produced by killing off these parasites, by killing off these substances, or the debris from all this breakdown is there. So two things actually. One thing is debris, which was present at the base, and second thing was fibrin, which was present in edema fluid. So they both combined and they formed a hyaline membrane. Now this hyaline membrane is going to make it even more difficult for air to pass through. Then interstitium, you can see there was very minute amount of space present here, but the space has increased up to many folds here. Blood vessels are poured out. So we got to know that there are two basic structural differences in the structure. What two structures? First of all, we're going to get edema and then hyaline membrane. Edema because of endothelial injury, and that membrane, hyaline membrane, just because of that debris and the fibrin present within the edema. So let's talk about how it will be looking on a slide if we look at it. As you can see on a histological slide, you can see very, very major blood vessels. All the capillaries present here are now engorged. You can see them easily because there's a lot of blood pouring in. You can easily identify them. And you can see all the hypercellularity present inside the cells. Hypercellularity because we talked about all of these cells, all of these monocytes, nucleocytes, they all came in and they are going to affect it. Next on, as you can see, acute and organizing phase. This was just acute phase. In this phase, infection was happening. This process was happening. Now the body has decided to take care of itself. So when the body has decided to take care of itself, all of those cells are going to come in. So all of this slide that we see here, it is happening with acute infectious phase with organizing phase. In this phase, the body has decided to take care of itself. That fibroblast cells are there, they're going to regenerate it. And the debris will be taken care of through phagocytes or macrophages. So in this phase, only the infection was there. The body was not responding in the way to resolve this problem. But in this slide, the body is responding and the infection is happening. So there's a lot happening around here. You can see the engorged blood vessels. You can see the hypercellularity in the slide. So this will go on and on and on. So we have to know what will be the clinical features of this patient when the patient will present to you with this disease. First of all, there will be tachypnea. Why do you think tachypnea will be happening? Because the patient is unable to properly saturate the blood with oxygen, because many of the air spaces, many of the alveoli are under the influence of diffuse alveolar damage. So they are not communicating. So they are not, respirating. They're not giving the blood that much oxygen. So only some alveoli are present, which are doing the function. So it's a lot of burden on those alveoli. So they can saturate the blood up to some level. So in order to increase that efficiency, to increase that level of saturating the blood, they're going to cause tachypnea. Patient will inspirate and expirate a lot. Patient will be more than 80, more than 90 minutes per, more than 60 to more than 80 minutes, 80 breaths per minute. Next on, we have dyspnea. When the patient is having tachypnea, patient will be fatigued, patient will have dyspnea. Next, we have arterial hypoxemia, because that arterial blood is not properly saturated with oxygen that we are used to see. We used to see the blood at 98%, 99%, or at least above 90. In this patient, that those levels will be below 90, because there's not enough time and not enough space for the lungs to completely saturate the blood because of those damaged alveoli, those alveoli which are under the influence of diffuse alveolar damage. Next on, we have alveolar infiltrates. When we go for radiological slide for this patient, we're going to have alveolar infiltrates. And next on, we will have decreased partial pressure of carbon dioxide, because carbon dioxide is going to go in any way. So some of it may start accumulating. So decrease of partial pressure of a carbon dioxide will be happening. Next on, we have neonatal respiratory distress syndrome. Why do you think neonatal respiratory distress syndrome happens? It happens because of surface tension. And the only and the sole function of keeping that surface tension low in a baby, in a neonate, is of surfactant. Surfactants are actually phospholipids which are produced by type 2 cells in the lining of that epithelium. So when there's decrease in surfactant, the surface tension will increase and alveoli will collapse. That's why neonatal respiratory distress syndrome happens in a patient, in a neonate. There can be multiple causes of this happening. This can be happening in any case, in any pregnancy which is preterm. We're going to talk about the factors which are responsible for it. First of all, as you can see, this is a neonate. And if you look at the lungs, if there's a normal alveoli, this will be the posture of a normal alveoli. This will be the looking of a normal alveoli. But this will be the looking of a collapsed alveoli. Collapsed alveoli because the surface tension is too much and the alveoli collapsed because surfactant was not enough. So the thing is, a patient, if a patient is going to have a baby through C-section, you should be very careful with that, because at the age of 24 weeks, preterm baby, at the age of 24 weeks, the surface tension of the lungs is significant, so the surfactant production increases. But the major part of surfactant is produced through 36th week of pregnancy to 40th week of pregnancy. So if a baby is preterm, if a baby is being born at 35 weeks, maybe that baby does not have enough surfactant to come out and breathe in the normal air. So we have to be careful. All those mothers who are alcoholics, they're going to get it. It even runs in the families in some cases, that patients are going to get it. And the patients who are going through C-section, we should be very careful and we should be kind of ready to deal with this issue. When a baby is born through neonatal respiratory distress syndrome, the signs and symptoms will start to appear in maximum of 5 minutes. Baby will start turning blue, the nails will turn blue. You will know the baby is suffering from neonatal respiratory distress syndrome because all of those alveoli have collapsed. So they're not communicating with the blood. They're not giving their part in communication. So this will be the look of a patient, of a baby who's suffering from neonatal respiratory distress syndrome. It actually has 4 stages. It actually has 4 levels of neonatal respiratory distress syndrome. In the first level, there will be only small part of alveoli which are damaged, and we'll see the consolidation of them, or this kind of shadowing in them. Mirror glass shadowing is what it's called in neonatal respiratory distress syndrome. Whenever you hear this name, glass shadowing, you should be alerted to know that it's going to be either neonatal respiratory distress syndrome or some other major disease. In the second level of it, opacities will grow. And third level, they'll grow bigger. But in the fourth level, it will involve both lungs and all the lobes of it, like it's affecting here. And it will, in some cases, it will even mask this angle that we see of heart. On a pathological slide, we see this kind of pattern in neonatal respiratory distress syndrome. As you can see, the alveoli are collapsed, blood vessels are there, but they're not functional at all. Some are even closed. Next on, we have alveolar proteinosis. We talked about the alveolar lung diseases are those diseases in which either the fluid is accumulated. We talked about the fluid in diffuse alveolar damage. In diffuse alveolar damage, edema was happening, fluid was happening through endothelial levels, through endothelial tissue. Through the damage of endothelium, it's pouring out, and that edema is causing those diseases. Now we're going to talk about alveolar proteinosis. So we talked about how water affected it, how edema affected it, how the fluid affected it. Now we're going to talk about how protein is going to affect it. As you can see in this diagram, this is a normal alveoli. This is a normal structure of the lung. You can see these are bronchioles, these are alveoli, air sacs, and these are air spaces. This is a normal alveoli. But as you can see, when alveolar proteinosis is happening, these are actually filled with proteins and fluids, and buildup of protein surfactant is happening. So why do you think the protein is just accumulating there? It's because of a problem, because of a defect in the system in which the surfactant, phospholipids, and phosphoprotein and those lipoproteins start accumulating inside the air sac. That surfactant, which had those normal amounts of lipoproteins and lipids, is now having increased amounts, and they are not being cleared up. So there can be 2 causes of it. Either it's increased production of these things, either it's decreased clearance of these things. It can be either one of them. It can be either the production is increased and the body has not been able to clear that up, all of it. But it can also be that production is normal, but it's not being cleared up entirely. So it can be either one of them. In its pathogenesis, let's talk about its pathogenesis. How does this happen? So there are some risk factors which are present, including a patient who smokes, and there are multiple factors, and in this A, B, C, D proteins also accumulate in that. So let's talk about the pathogenesis of it. As you can see, there will be autoimmune PAP present inside of it, but there are hereditary PAP also present inside of it. So there will be contraindication already. They will be contraindicated in somehow. Then secondary PAP will be there, which will do this, which will reduce this. And then we have transcription factor, which will multiplicate the whole system. And then we have surfactant production disorder. When the surfactant production disorder will be happening, there will be production of undegraded surfactant. This undegraded surfactant will lead to the accumulation of lipoproteins, and those lipoproteins are somehow going to affect the alveoli in such bad manner that it's going to cause alveolar proteinosis. In a slide, if you see a patient's lung who has been suffering from alveolar proteinosis, you can see this kind of structure. They're firm, they're gray, they have been subjected to this kind of disease for a long time. Next on, we'll see that there will be hypercellularity among them, but as you can see, the filling is too much. The spaces are filled with proteinaceous material. Next on, in imaging, we'll see this kind of picture. We'll see the cavities, we'll see the dense materials. First of all, we'll see the dense materials. those dense materials will be seen anywhere, but those dense materials will be later converted to opacities rather than those materials, opacities or cavities even. Next on we have diffuse pulmonary hemorrhagic syndrome. So we talked about the blood, we talked about the water, that edematous material and diffuse alveolar damage, that when water accumulated, what happened. Then next on, we talked about what will happen if proteinaceous material will be accumulating. And now we're going to talk about what if the blood is accumulating? What if the endothelial injury is that much that blood is accumulating? What will be the consequence of that? So diffuse pulmonary hemorrhagic syndrome will be consisting of three major other diseases, and some of them are even autoimmune. Let's talk about them. First of all, we're going to have Goodpasture syndrome. We're going to talk about Goodpasture syndrome, what it is, and how it affects the lungs, and how it affects the capability of the lungs to communicate with the blood, and how it affects the hypoxia in that patient. Next on, we have idiopathic pulmonary hemosiderosis, and in the last, we have granulomatous with polyangiitis. First of all, let's talk about Goodpasture syndrome. What is Goodpasture syndrome? Goodpasture syndrome is actually an autoimmune disease in which there are antibodies present inside the body which are subjected to kill the basement membrane. As you can see, in Goodpasture syndrome, anti-GBM, anti-glomerular basement membrane antibodies are present which are going to attack at the basement membrane, and somehow that basement membrane will rupture. That basement membrane will degrade. And what will happen? The blood will start accumulating inside the alveoli. It will cross the barrier, it will start accumulating the alveoli, and Goodpasture syndrome will be happening. Goodpasture syndrome affects two major areas, kidneys and lungs. 90% of the patients get both of them together. It's not like only lungs will be affecting, it's not like only kidneys will be affecting. It's actually a combination of them two, combination of both of them. So in Goodpasture syndrome, anti-GBM proteins are present, anti-GBM antibodies are present, which are going to attack the glomerular basement membrane and cause this effect. As you can see, this is a slide of a basement membrane which is kind of destroyed because of it. In pathology, when you look at a slide of a patient who has been suffering from Goodpasture syndrome, you can see the bloody stain on the lungs throughout, because endothelial injury led to the bleeding and accumulation of blood inside the alveoli, and it led to alveolar lung disease. Next on, we have clinical features of a patient who is suffering from Goodpasture syndrome. What do you think we even have to think about it? We all know the clinical features, you just have to break your mind into it. First of all, we're going to have hemoptysis, because the blood is accumulating inside of your alveoli. You're going to have hemoptysis. Whenever you'll cough, the blood will come out, or at least some part of that blood will come out. So the patient will present to you with hemoptysis, that whenever I cough, I have blood in my cough. I have blood in my sputum. Next on, patient is going to have dyspnea. Dyspnea, why do you think dyspnea is happening? Because the patient which got hemoptysis, which got accumulation of blood inside of your alveoli, is not respirating enough, is not communicating with the blood enough, is not saturating your blood with 100% oxygen. So the patient will have dyspnea. Next on, the patient will have weakness, because patient cannot perform in a deoxygenated state. Patient cannot perform when all the body tissues are not getting enough of the oxygen. Patient cannot perform when the capability of the blood to oxygenate them, to nourish them, is not good enough, is not up to their peak. Next on, we will have mild anemia because the blood is being poured out into the alveoli, and then from the alveoli it's being coughed out. Hemoglobin breakdown will happen, and patient will lead to anemia somehow because of the loss of the blood and all the infection, all the process that's going on around here. Then we have hypoxemia, because oxygen levels are going to go down, because not enough air space is present inside the lungs to saturate this much amount of blood in this time. Next time we'll have respiratory alkalosis, because all of this is happening. All of this will lead to actually respiratory alkalosis. pH will go up. Next one, let's talk about the idiopathic pulmonary hemosiderosis. It's a disease, it's a pathology in which we don't even know the reason behind it. So we're going to focus on the clinical features of the patient who's going to present to us with this kind of pathology, with this kind of disease. First of all, the patient will have cough because of accumulation of this kind of substance in the alveoli. Patient is going to have cough, obviously. Then we're going to have dyspnea because patient is not saturated enough with oxygen. Patient will have subcellular chest pain because of this blood and fluids and stuff accumulating and the reaction of the body, and patient is going to have subcellular chest pain. Next one, we'll have fatigue of the patient because patient is unable to carry any kind of activity because the tissue and the muscles are not even oxygenated enough to carry out those functions. Next one, we'll have iron deficiency anemia because the blood is pouring out, so is the iron, so iron deficiency anemia is happening. Then we'll have pulmonary hemorrhages because the blood is pouring out, so that's why it's called pulmonary hemorrhage. Pulmonary hemorrhages will increase with time because in some points, at some time, it will be happening at one side, but after some time, it will be happening at multiple sites, and this will lead to a proper term of pulmonary hemorrhages. Next on, we have the pathology, and the slide says it all. As you can see, a lot of breakdown is happening, a lot of blood cells are coming in, coming out, and the blood cells are being accumulated here. So we don't even know the reason behind it, but we just know that blood is accumulating inside of it, and the body is unable to communicate with the blood vessels. The alveoli are unable to transfer the oxygen and take the carbon dioxide out of it. So that's why it's just happening again and again. So in a patient who's suffering from idiopathic pulmonary hemosiderosis, this is the kind of chest x-ray that patient will get. You can see the haziness around both sides because of it, because of the accumulation, the alveolar levels are compromised. Next one, if we take at the film at this level, you can easily see this kind of, you can see the infection present. You can see some areas are not even communicating, some areas are full, some areas are not even there for the gases exchange. Next on, we'll see what are the manifestation of granulomatosis with polyangiitis. So this is the most severe form of these three. This is the most severe of them. First of all, it's not going to affect only your lungs, it's going to affect you multiplicately. So let's talk about it. And first of all, in oral cavity, ulceration throughout oral mucosa will be happening in this kind of patient. Why do you think this is happening? Actually, it's an autoimmune disease. In this disease, immunity turned on itself, and it's going to destroy everything in its way. Which structures are going to get destroyed? We're going to talk about them. First of all, oral cavity will be destroyed. A lot of ulcers will happen on the oral mucosa. Next one, we will have eye involvement, which will include pseudomotors and conjunctivitis. Next one, we'll have nose stiffness, nosebleeds, and saddle nose. Next one, we'll have in the lungs, we'll have cavities, bleeds, and infiltrates. We're going to talk about this section, this lung section, right now. But before we move on to that, we need to know that in heart, it causes pericarditis. In skin, it causes nodules on elbow and purpura. In kidneys, it causes glomerulonephritis. So basically, two structures affected most of it, kidneys and lungs, and their involvement is most probably going to be simultaneous. Granulomas and patchy necrosis in blood vessels will be happening in this case. And next of it, positive anti-neutrophil cytoplasm test is performed in this case. Because anti-neutrophil means antibodies are present inside which are going to kill the cells which are going to protect us inside of it, and we won't even know. We won't even know the difference. We won't even know the reason behind it. So let's talk about the pathogenesis of it. First of all, T cells will be coming down. It's an autoimmune disease. It's going to destroy itself. So what will happen? A lot of cellular activity will be happening inside that. Neutrophil will be activated that somehow there's an infection or there's some killing happening, and I don't even know. I don't even know that any organism came in. I was not informed. So neutrophil activated, neutrophil will go in, they'll see what's happening, and somehow due to autoimmune disease, it's killing the basement membrane. It's already killing the basement membrane. Neutrophils are activated, but the endothelial damage has already occurred. and macrophages will be activated. They'll start eating it up, and NTA3A and CA will be present. Now this is a major thing to remember. NCA, we also call it NCA and CA. NCA will be seen in this condition. So this will lead to these B cells formation, and somehow it will lead to granuloma formation, in which all of this will coexist, and granuloma will be formed inside of lungs. So this is how it looks like on a pathological slide. You can see the granuloma, you can see the hypercellularity, you can see the infection happening inside of it, you can see the engorged blood vessels, you can see multiple bleeding sites in this slide. So you will be looking at what will be the radiological slide of the patient who is suffering from granulomatous with polyangiitis. So first of all, in the acute phase, all we'll see is consolidative masses. We can see the masses, we can appreciate the masses and consolidation in this. But as we move along, as the body tries to heal itself, as the immunity takes care of it, it will be resolved. After some time, it will be resolved. These masses will be resolved. These consolidations will be gone, and they will be converted into cavities. As you can see, cavities, you can actually see them happening. Look at them. These cavities are formed afterwards. Next on, we'll have eosinophilic pneumonia. Eosinophilic pneumonia is an acute infection of the lungs in which patient is going to have hypoxemia, in which patient is going to have inability to even work properly. Patient will have febrile illness, and there's no sign of any infection, no proof of any infection present. And there's bronchoalveolar lavage eosinophilic. Bronchoalveolar lavage of eosinophilic. That's why it's called eosinophilic pneumonia. So this will be the slide looking like. You can see the stain. You can see, you just look at it and you will be saying it's eosinophilic. Next on, we'll have the types of eosinophilic pneumonia. First of all, we're going to have either it's idiopathic. We talked about it, that in some cases we don't even know, we don't even appreciate any kind of infection in that patient. So patient is going to have idiopathic type of eosinophilic pneumonia, or the patient, if a patient is suffering from idiopathic pneumonia already, it can be chronic eosinophilic pneumonia. That patient might getting it again and again, and there's no resolution whatsoever. Next on, it can be acute eosinophilic pneumonia. Maybe the patient got it, we don't know the cause of it, but patient healed itself. We didn't take any medication because we didn't even know if it's an infection or not. The patient revived on its own. The patient healed itself. The immunity took care of it. And then comes simple eosinophilic pneumonia, type of eosinophilic pneumonia in which a simple medication will be enough. A patient will be presented to you with a cough, and if you go for the chest x-ray, the consolidation will be seen. Next on, we have secondary eosinophilic pneumonia. Now, it's not idiopathic. As you can see, idiopathic contains only three of them: chronic eosinophilic pneumonia, acute eosinophilic pneumonia, and simple eosinophilic pneumonia. In secondary eosinophilic pneumonia, we'll have the cause. Either it's going to be infection, and infection, it's going to be parasite, and among parasites, we have tropical eosinophilic pneumonia. It happens in a certain region. Certain regions are very famous for getting this kind of pneumonia. Mostly it's in African countries. Next on, these parasites will be Ascaris lumbricoides or Toxocara canis or filaria. Ascaris lumbricoides is also present inside the Asia, so you might get it somehow. Dirophilaria is also common. And next on, we have fungal infections. First up, we talked about parasites. Parasites contained Ascaris lumbricoides and Toxocara canis and filaria. And in fungal infections, we're going to have Aspergillus only, because Aspergillus is the only fungus which is going to cause this kind of pneumonia. Next on, we have drug-induced. And in drug-induced, it can be because of antibiotics and cytotoxic drugs and anti-inflammatory drugs which are used abundantly in any kind of society. Antihypertensive drugs can cause it, and L-tryptophan is an example of it. L-tryptophan also causes it. So now we know there are two kinds of eosinophilic pneumonia actually. First are idiopathic, we don't know them cause. Some are acute, some are chronic. Acute will take care of itself, chronic will not. We will have to interfere with some kind of modality Then there comes simple eosinophilic pneumonia, which contains all the symptoms, but it doesn't complicate things for us. Next one, we have secondary eosinophilic pneumonia, which is after the cause of something, we know the cause. Somehow we grasp the cause. And this can be either infection. Infection can be either parasitic or fungal infection. Fungal infection will be aspergillus. Parasitic infection will be Ascaris lumbricoides. And in drug-induced, 5 drugs are going to cause either antibiotics, cytotoxic drugs, anti-inflammatory drugs, antihypertensive drugs, and at the end, L-tryptophan. Next on, we have immunological or systemic diseases. Immunological mean autoimmune diseases. The body has tried to decide the cells of its own body. This includes allergic bronchopulmonary aspergillosis. Next on, we have eosinophilic granulomatosis with polyangiitis. We talked about it earlier. Next on, we can have hypereosinophilic syndrome. On a pathological slide of eosinophilic pneumonia, we'll see them cavities, we'll see them holes inside of it. You can appreciate this kind of appearance will be present on eosinophilic pneumonia. What are going to be the clinical features of eosinophilic pneumonia? First of all, patient is going to have fever. Fever because maybe it's infection, maybe it's sepsis. Next, patient is going to have night sweats. Next on, patient is going to reduce the weight, lose the weight. Because it can be either one of them. The cause can be either one of them. Patient can be suffering from fungal infection. Patient can be suffering from parasitical infection. Patient can be suffering from autoimmune disease. Patient can be suffering from any other cause which is unknown to us yet. So the patient, because of that infection, is going to lose weight. Next on, we'll have cough productive of eosinophils. So next on, we'll have cough because the alveoli are damaged, the alveoli are getting damaged, all the areas are getting damaged. The patient will cough. When the patient will cough, the sputum will be of this color, that we call it cough productive of eosinophils. If we go for the culture, if we go for looking for it, we find eosinophils in it. Patient will have dyspnea because the patient is unable to saturate the oxygen to its saturate the blood to the maximum of its oxygen content. Next on, patient is going to have asthma. Now, asthma is periodic episode, but this is not. If it's chronic, it's not. So patient can have even chronic asthma because of it. Next on, we have endogenous lipid pneumonia. So there are 2 kinds of this kind of pneumonia. Either it can be endogenous, either it can be exogenous. First, let's talk about endogenous lipid pneumonia, in which lipid is present inside it. Inside of it, lipid is present. As you can see, these are clear markings. Hypercellularity is already present, but these are clear markings present around it. Then we have exogenous lipid pneumonia, in which, as you can see, alveoli are untouched. These spaces are fine, but you can see the hypercellularity and the engorged blood vessels and the increased blood vessels, increased blood cells, and lipids outside of it. So what are going to be the etiological factors? COD liver disease or COD liver oil. Petroleum jelly can be the cause of it. Olive oil can be the cause of it. Mentholated tropical ointment can be the cause of it. And Primorse oil can be the cause of it. And flavored lip gloss can be the cause of it. We ingest these things, somehow they get into it, and those lipids are accumulated outside of it. That's why it's called exogenous lipid pneumonia. It's going to, give that kind of influence to the lungs, that infection will happen and it will lead to this kind of pneumonia, and that will complicate things for it. So these can be the etiological factors, these 5-6 factors, which are actually our usable things, which are actually things we interact with. And somehow, if they get entry to it, they're going to cause exogenous lipid pneumonia. Let's talk about what the pathological slide of exogenous lipid pneumonia will look like. So this is what it looks like. The alveoli, you can see they're not affected by this kind of lipid intrudement, but you can see the lipid involvement outside of it. If you go for radiological findings of it, you can see this accumulation of lipids. You can see very clear markings of it, and that's how you define it. It's exogenous because it's not affecting the alveolar level, but it's affecting what's around of it. As you can see it in here too, these structures are very identifiable. So in this lecture, we talked about what factors are going to affect and lead to alveolar lung diseases. We talked about it can be water, it can be edema, it can be blood, it can be proteinaceous material, it can be lipids. So we start with diffuse disease in which the edema was happening because of endothelial damage. All of that water was pouring into it. That started accumulated. That started accumulating, and somehow it reached up to the level that it caused the infection. We talked about in some cases it's going to be aerated, in some cases it's not going to be aerated. It's easier for us to diagnose the patient with this disease if the patient, that area of the alveoli is not aerated at all. But if it's aerated, it's going to be difficult for us. But somehow, even if it gets its hands on it, the patient will have consequences like dyspnea and fatigue, and patient won't be able to carry out its normal functioning. Then we talked about if it's going to be blood, and then we talked about hemorrhagic disorders. Then we talked about those disorders which cause the blood to accumulate inside the alveoli, the blood to pour inside the alveoli, not only the water. So those were Goodpasture syndrome, in which autoantibodies are already present, autoimmune diseases happening to the patient. So there are like proteins called anti-GBM, anti-glomerular basement membrane proteins, which are going to attack the basement membrane, which are going to disrupt the basement membrane. And in return of the disruption of the basement membrane, blood will start pouring out inside the alveoli and accumulate and cause the infection. And that's Goodpasture syndrome. Then we talked about granulomatosis with polyangiitis. In that disease, we talked about its autoimmune disease. It's going to get to lungs and then get to kidneys and affect them in such a manner that these both affect the whole system of the body. In some cases, in like 10% of the cases, only lungs are affected, and in 10% of the cases, only kidneys are affected. But if we look at it, in 80% of the cases, the effect is simultaneous. Both the organs are being affected. And we might think that only lungs and kidneys are being affected, all the other systems are working fine, but no. When these two are getting affected, it's going to affect the cardiac system. It's going to affect the GIT system. How is it going to affect the cardiovascular system? Why do you think vasoconstriction happens in this case? Vasoconstriction happens because there's not enough space, there's not enough alveolar space present to communicate with the blood and saturate it with oxygen completely. When it's unable to saturate with oxygen completely, what's going to happen? Vasoconstriction will happen. Vasoconstriction will lead to pulmonary hypertension. And then it will lead to pathological effect of right ventricle, then right atrium, and somehow it can even lead to, if this problem goes on and on and on, this can actually lead to cardiac failure. And if kidneys are affected, kidneys control our blood pressure. So a lot can go wrong because of this disease causing the effect on lungs and the kidneys. Next on, we talked about the proteinosis. We talked about it can be idiopathic. We might even not know the cause of it. And then we talked about pneumonia, eosinophilic pneumonia. Eosinophilic pneumonia was an infectious cause, but it was a disease that we were not sure about. It's idiopathic in most of the cases. In primary cases, in basic cases, it's idiopathic. It's called eosinophilic pneumonia because in the sputum you'll find eosinophils. There's a stain of it when you do it. And what happens is, in some cases, drug-induced. In some cases, like antibiotics and stuff like that, it's going to cause it. In some cases, it's fungal infection because of aspergillus. It can be either due to bacteria, it can be either due to parasites, basically parasites. We talked about those parasites. So all of this can accumulate and cause eosinophilic pneumonia. Then we talked about, at the end, all of these things are discussed earlier. Water is discussed, fluid is discussed, blood is discussed. Now pus is discussed because of eosinophilic pneumonia. At the end, we talked about lipids. Lipids can be endogenous, lipids can be exogenous. Endogenous lipids can be due to systemic failure or systemic problems, but exogenous lipids is due to all of those factors we discussed, that these can be in your intake, or somehow it reaches up to that level, it blocks them activities, but the alveoli is safe. The inside of the alveoli is safe, but outside it's filled with the lipids, and it leads to this pathological form. So this is how we circulate the alveolar lung diseases. Thank you for watching sqadia.com.